Good evening, and thank you everybody for attending tonight. We're delighted to have Reanne Booker present this webinar for us. Reanne is well known to AMAC. She's been a board member with us and has presented another time and number of times, and also is the winner of our Nurses Foundation award that we award every year. So I'm just going to turn it right over to Reanne.
Thank you very much, and thanks to those who have joined, and thanks to those who will join at a later date and watch this webinar at some point in the future. I'll just share my screen here, and hopefully this will work. And maybe, can you just give me a thumbs up or let me know if you can see those slides? Okay. Well, I'll keep talking. Cindy, if you're able to just let me know that you can see the slides.
Yeah, they're up.
Okay, wonderful. So thanks very much for the invite to speak this evening. I have done this talk a number of different times. Usually it's in the context of cancer, but I think a lot of the content is very applicable to the context of serious illness as well. And actually, to be fair, a lot of the content also is applicable as many of us age, as all of us hopefully will age. Not rapidly, but as we age, some of these changes can be quite expected and normal as well. So I don't have any conflicts of interest to declare that would be relevant to this talk. In particular, I've received some funding for my PhD studies, as Cindy mentioned. I'm a very grateful recipient of an AMAC scholarship, the Liz Lemire Memorial Scholarship, and the Marilyn Convey Scholarship as well. And so you may know that Liz Lemire, this is awarded through the Alberta Registered Nurses Educational Trust. Liz Lemire was an AMAC member, and she was a teacher in Calgary, Alberta, and had a bone marrow failure disorder and set up a scholarship in Alberta. And then Marilyn Convey, I met a number of times at our Canadian Association of Nurses in Oncology conference. And she was also an AMAC member and did a lot of work in educational initiatives, particularly around educating nurses and healthcare providers about bone marrow failure disorders. So just to make a disclaimer here, of course, this presentation is for information and educational purposes only. It's not a substitute for medical advice. Always talk to your healthcare team before you make any changes, or if you have any additional questions. You're also welcome to email me directly if you have questions, and I might be able to provide you with some further information that you could take to your care team if you like. So this evening, I'd like to talk about the potential impact of bone marrow failure treatment and chronic illness and serious illness overall on sexuality and intimacy, and then talk about some strategies to help optimize sexual health and intimacy after a diagnosis of bone marrow failure disorder or chronic illness overall. So years ago, when I started in cancer care, which would have been in 2000 or 2001, I worked in a variety of different cancer care clinics. Some of them dealt with genitourinary types of cancers like prostate cancer and gynae cancers and things like that. But I also worked with patients who had blood cancers. And the topic of sexual health was always something that we asked in the patients with prostate cancer and testicular and the gynecological cancers and such. But we didn't ask it very often in patients with other types of cancers. And I started asking the questions in the hematology clinics that I was in. And patients had a lot of concerns about sexual health in the blood cancer clinics as well. And we've since come to learn through the literature and just in clinical experience that sexual health is very important to patients throughout the lifespan and illness trajectories. And also it can be very impacted by disease and treatment, irrespective of what the diagnosis is. So it doesn't matter if it's just prostate or breast or GU type of cancer, or a blood cancer or something else, or another serious illness. We know that sexual health can be profoundly impacted. Pardon me. So we know also that people come into a diagnosis, medical diagnosis, with a bunch of different factors that could influence sexual health. So things like age, if they have a partner or not, previous experiences, culture, religion, other medical conditions, psychosocial history, so things like anxiety, depression, relationships, and things like that. Of course, the disease itself, and that could be cancer, it could be bone marrow failure disorder, it could be any number of medical conditions there. And then the various treatments that we provide So sometimes the diagnosis in and of itself is enough to impact sexuality and sexual function. So things that impact neurovascular status, or so nerve function or blood flow or hormone function, any medical condition that impacts those things can also impact sexual function. And as I mentioned already, we know that as we age, there's a lot of different changes that happen with those systems that can impact sexual function adversely as well. And then there's a whole array of things that we do. So the medical treatment that comes with its own side effects and symptoms and different things like that can also impact sexual function in a huge way. Oops. So again, in my experience, and I ran a sexual health clinic at our cancer center in Calgary for a number of years, and I've done some studies on sexual health and in the context of cancer. And a time of diagnosis is probably not when a lot of people are thinking about sexual health concerns. And so, most people rightly at that time have bigger questions on their mind in terms of, what do I need to get through this treatment, and what are the options? How will this impact my life overall? Survival, of course, is top of mind for most people, I would say. But if people are thinking about fertility preservation, that is a time when we want to start having those conversations, is ideally at diagnosis before treatment starts, because as soon as treatment starts, there can be a significant impact on fertility, depending on the type of treatment that is being offered. So then during treatment, again, a lot of people may not have sexual function and sexuality as top of mind. Most people, again, are focused on getting through the treatment and feeling as good as possible while they're going through the treatment. But for some people, they really desire physical closeness and intimacy, and it doesn't necessarily have to be sexual intercourse or sexual activity, but even that physical closeness and intimacy can be very important. And a lot of patients have questions about, is it safe to have sexual activity, and what kinds of things might not be that safe to do during treatment for the partner and the patient. And so we'll speak a little bit about that further on. And then in recovery and survivorship is probably when we saw most of the patients in our sexual health clinics. So they'd finished their primary treatment for their cancer, and then they would come to our clinic once their treatment had finished. And that, again, is a period of time where people are trying to, move away from the treatment and different things like that, and focus on trying to get back to, I don't like to say get back to normal, because things usually are not ever normal necessarily again, but trying to regain some of the quality of life that was really impacted by treatment. Another time where people might think it's not important to think about sexuality and sexual health is advanced disease and at end of life. But again, this is where some patients that I've worked with really desire that closeness, to be close to another person. And again, I'm not speaking solely of sexual activity here, but the physical and emotional intimacy that really is part of what make us human, can be really something that people are keen or strive to have even at end of life. And a number of years ago, it was probably 3-4 years ago now, I think it was before COVID, I was asked to give a talk at a hospice in Calgary, because some of the staff walked in on one of the patients in the hospice and the partner, and they were engaging in some activity, and the hospice staff were shocked that this would be something that would be of interest to the patients in the hospice. But of course, this couple really desired that physical closeness. And so we talked about, well, maybe there needs to be some strategies and some thinking about how can we optimize privacy and ensure that patients and their partners, still can have that emotional and physical intimacy should they wish. And so in terms of female sexuality, and I'll make the point again that sexuality is a much bigger concept than just sexual function. So we often focus a lot on sexual function, what's working, what's not working. But sexuality is a much broader concept and encompasses things like body image, self-esteem, and relationship aspects and things like that. But when we're speaking specifically about sexual function, we know that there can be all these different changes. So again, anything that's going to impact blood flow, nerve function, hormone function, can also impact sexual function. Some of these things will happen with normal aging and menopause for women anyway. There can be decreased interest in sex, changes in arousal, dryness, vulvar and vaginal dryness, which can then lead to painful intercourse, which then itself can lead to decreased interest in sex. You can imagine if things are painful, it can really cause diminished interest. Different types of treatment can cause ovarian failure, and that might be temporary, but for a lot of women, it's permanent. And then different disease and treatment specific interventions. So in terms of bone marrow transplant or stem cell transplant, if the cells are coming from another person, not the patient, so they're allogenic transplants, there can be graft versus host disease. And in our clinic, we saw a lot of women with vaginal graft versus host disease that was very severe. And even that profound loss of estrogen that can happen after bone marrow transplant. It led to really severe narrowing of the vagina and even stenosis. And you know, some women we saw, it was very difficult to even get like a pinky finger in, which is not just a sexual health issue, but it's a pelvic health issue, because then it becomes difficult to do pap tests and pelvic exams and things like that. Of course, depending on the type of treatment, there can also be altered fertility. And then, as I mentioned, the psychosocial aspect as well. So body image, self-esteem, depression, anxiety, relationship challenges. These are all very common after a chronic illness diagnosis. And with men as well, we see a number of different changes. And again, the top is pertaining to sexual function. So there can be reduced interest. There can be a lot of difficulties with the erectile function. So that probably, with the women that came to our clinic, the most common concern was vaginal dryness and painful intercourse. And for the males who came to our clinic, the most common concern was erectile challenges. And so, of course, we know that this can happen with normal aging as well, but certainly the treatments that we offer in the cancer care world and even in the bone marrow failure world can cause erectile difficulties. Less commonly, we can see ejaculation changes. That happens more often with prostate cancer and other types of cancer treatments. Changes in orgasm, if there's neuropathy or nerve damage, again, that can impact orgasm. Different types of treatment can impact hormone function. Similar to women, there can be graft versus host disease if there's been an allogeneic transplant. Altered fertility as well. And for some men, this can be, the fertility can be regained, but for some it'll be more long lasting. And then men, just like women, can have profound body image and self-esteem changes, depression, anxiety, and relationship difficulties as well. So, I mean, outside of the context of cancer, even alone, we know that all these different medications can also impact sexual function. So some of these are common, and certainly as we get older, many of us can expect to be on these medications. Antidepressants can cause reduced orgasm in males and females. Blood pressure medications, so antihypertensives, can cause reduced desire and interest, problem with orgasm as well. Anti-seizure medications, which we also sometimes use to treat pain, especially nerve pain, can also lead to problems with orgasm, arousal, desire, decreased testosterone in some cases. Anti-ulcer medications, they can lead to decreased arousal. This seems to be less of an issue with the proton pump inhibitors like pantoprazole or omeprazole. And then, of course, our chemotherapy drugs, we know can cause significant issues with nerve pain and nerve dysfunction, nerve impairment, neuropathy overall, erectile function, ejaculation problems, vaginal dryness, painful intercourse, and orgasm problems as well. Different herbs and complementary medicines can also lead to changes in sexual function. For sure, different illicit drugs can have adverse effects on sexual function. And then the IMiDs, or the immunomodulatory drugs, things like lenalidomide or Revlimid, thalidomide, those can lead to erectile changes, decreased interest and desire, nerve dysfunction or neuropathy, and steroids like dexamethasone or prednisone, corticosteroids, can cause reduced arousal and problems with erection as well. So a lot of these drugs are fairly common, even outside of the diagnosis of bone marrow failure or cancer, and they can have a significant effect on sexual function in males and females. And so changes in desire, and we know again that this is something that can happen as we age. And it used to be that there was this kind of linear sexual response cycle where, you know, we thought that spontaneous desire would happen, and then that'd be followed by, you know, excitement, arousal, orgasm. But more work has been done on this, and this is Rosemary Basson, and she's a clinician researcher from British Columbia. And she's done a lot of work in this. And in particular, she's found that you don't necessarily need to have that spontaneous desire or that spontaneous sex drive. And that's very often mediated by hormones. And so if there's that absence of that spontaneous sex drive, so somebody's not really feeling in the mood or interested, sometimes people just shut it down there. They say, well, I'm not interested. I'm not in the mood. I don't even want to pursue anything, thinking that the rest of that cycle, if you think of it as a linear thing, if you take out the first step, can you still be successful in the other steps? And the answer is yes, you can. You don't really need necessarily to have that spontaneous sex drive. So you don't have to have that interest first. That interest might come after. So an example a colleague of mine in California likes to give is that, you might not be in the mood, but then your partner might come along and start giving you a shoulder rub or maybe talking a little sexy to you. And then all of a sudden you might be a little more interested, or that interest may still not be there. Arousal might come first before that desire. And so it need not be this, linear fashion where one step precedes or follows the next. It can be out of order. So just to keep that in mind, that if that spontaneous desire, that, good to go at any time, or that feeling of just being interested or in the mood, doesn't always have to be there in order for you to go on and have enjoyment in the other aspects of that sexual response cycle. So again, as I mentioned, women can experience a lot of changes. A lot of these are due to altered hormone function. So a lot of this is expected with natural menopause. We know that treatment that we give for cancer and also for some of the bone marrow failure disorders can push people into menopause more rapidly, more abruptly, and it can be more intense than natural menopause. But many women going through natural menopause alone, even in the absence of those medications and treatments and things, can still experience these changes. So when there's reduced estrogen in the body, we can see all kinds of different changes with the vulvovaginal tissues. There can be dryness that can lead to discomfort or pain with sexual activity. There can be bleeding after sexual activity. That, of course, as you can imagine, can negatively impact arousal, orgasm, desire, and interest. There can be irritation, burning, itching. There can be pain with urination. And there can also be frequent urinary tract infections after menopause. And this has to do with the pH changing after menopause. The pH of the vagina changes, and different bacteria that are not normally there can move in and cause problems. And so we can see all kinds of different physical changes in the vulvovaginal tissues that can make sexual function more difficult as well. And in the cancer world, we know that this can be one of the most distressing aspects of cancer treatment for young women, is being thrust into this early onset menopause. And again, for many people, this doesn't ever reverse itself. So this will be a permanent state. And so a young woman might be in their 20s, and they may have entered then into a permanent early menopause. And whereas things like the hot flashes and the vasomotor symptoms, they tend to improve the further one is in menopause, the vulvovaginal symptoms don't improve. And in fact, they'll actually get worse if we don't do anything about them. And so for men, as I mentioned, there can be lots of changes in erectile function. And again, we know that about 40 to 50% of men after the age of 40 will have some challenges with erectile function, even in the absence of any major medical diagnosis. So again, anything that impacts blood flow, nerve function, hormone function can cause problems with erections. So we're thinking of things like cardiovascular disease, diabetes, hypercholesterolemia, high cholesterol. All these different things can cause problems or lead to problems with erectile function as well. So it can be difficulty getting an erection, maintaining the erection. The firmness can be insufficient for vaginal or penile or vaginal or anal intercourse. And an erection needs to be about 30% firmer for anal intercourse than for vaginal intercourse. There can be loss of spontaneous erections as well, and loss of those early morning or nighttime erections as well. And a lot of work has been done, especially in the prostate cancer field, looking at the reasons for challenges with erectile function. And again, as I mentioned, there can be problems with nerve damage that can be due to medications or surgeries and treatments, changes to the blood flow, changes in hormones. There can be a real psychological impact as well, especially if there have been challenges and we don't address the challenges. There can be a lot of performance pressure, performance anxiety, and different things like that. And for a lot of men that I've seen over the years, it's a combination of many of these different factors. And so we are fortunate in our clinic that we actually had a psychologist who dealt with a lot of the psychosocial concerns. And I handled kind of more of the medical concerns and blood work and different things like that. But really, it takes both those approaches, a very biopsychosocial approach to really kind of get to the root of the problems. And we don't see this as much outside of prostate cancer and testicular cancer, but there can be definitely delayed or premature ejaculation. Again, if there's nerve damage because of treatments, different medications, radiation, and things like that. There can be pain with ejaculation, again, nerve damage. And so again, in the cancer world, we might see what's called epididymitis, or irritation of the epididymis from radiation, or irritation of the urethra. So again, in the bone marrow failure world, we sometimes do see total body irradiation before a bone marrow transplant or stem cell transplant. Typically, these kinds of changes are for many men, they tend to be temporary. And then, of course, in the prostate cancer world, we'll see all these other different kinds of changes with ejaculation that are not as common outside of the prostate or testicular cancer world. And changes in orgasm, again, as I mentioned, this can be common for men and women. So in the women, especially if there was a history or concern about painful intercourse, that was something that we would really want to tackle first, because if vaginal dryness and irritability of the vaginal tissues was causing pain, then it was really hard for a woman to be able to have satisfaction or orgasm. And again, satisfaction and orgasm are not necessarily tied together. You can still have a very satisfying encounter even if there is no orgasm. But conversely, I guess if it's very painful, it can be very difficult for a woman to have orgasm, or a male to have orgasm if there's lots of pain involved. So a lot of our assessment with orgasmic issues would be trying to figure out what the issues were. So there can be, for some, in the context of prostate cancer, some men would say that the orgasm was more intense. Some would say it's less intense. Some would say no change. I would say for the most part, in the people we saw in our clinic, a lot of people reported diminished or absent orgasm, less commonly painful orgasm. But again, if there was a lot of pain involved in the sexual activity, then there could be pain associated with orgasm as well, which seems a bit antithetical in some ways, or paradoxical, I guess. And then again, yes, as I mentioned, there could be complete loss of orgasm for some. And so we worked very closely individually with patients to figure out what the reasons were. And then we kind of tackled those and tried to get some improvement in this area. So I would say this is one of the areas in sexual medicine or sexual health that probably has received not as much attention, I guess, as some of the other areas like erectile function and things like that. And fertility could be an entirely separate talk. So the point to make about fertility, I guess, is that a lot of treatments for bone marrow failure disorder and different types of cancers and things like that as well can impact fertility, and that can be a permanent impairment in fertility for some patients. And so ideally, we like people to have conversations about fertility preservation before their treatment starts. That's not always realistic or feasible, because sometimes treatment has to start right away. So, thinking in the context of acute myelogenous leukemia, so that again could have been evolved out of a bone marrow failure disorder. We may not have that window to do. For a woman, we would need 4 to 6 weeks to do an egg harvest and embryo cryopreservation. For men, it's a little bit easier. We can store semen, and so it doesn't take as long for us to set that up. That can be a quick call to the semen analysis bank here in Calgary, or there would be something similar in most of the major centers across Canada. So it's a little bit easier to set that up for males than it is for females. But again, you still do need that little window for both to be able to set it up. And it can be expensive as well. So again, this varies by province in terms of what's covered. But there are different organizations that can provide some financial assistance as well. And body image. So this was a study I did not a couple years ago now, I guess it was more than a couple years ago, but it was for patients who'd gone through bone marrow transplant, and it was bone marrow failure disorders as well as cancers, blood cancers, and just looking at the experiences of sexual activity and sexuality. And what was interesting to me is that all the men in the study had as many concerns about body image as did the women. So body image was a huge concern for all the patients in the study. And this was a male transplant recipient, and he said, I remember the first time I looked in the mirror when I got up to go to the bathroom, and I literally fell to my knees sobbing because I didn't recognize the person that I saw. I'm trying to fight tears off now talking about it. I've mourned the loss of who I was. I was stronger physically. Now I might say 90% of what I used to be. I've got a much bigger heart. Some say it's the girl blood that makes me cry so easily. So he had a transplant from a female donor, and that's the reference to the girl blood. But his body image was profoundly impacted. And then another, as she mentioned, you might not feel that good because you don't have any hair or any eyebrows and tubes sticking out of you. So there's all that kind of stuff. But you know what? If your partner really loves you, you just see past it. My husband was, like, it's like you have a Brazilian. He's like, right on. So this patient, even though she'd lost all the hair on her head and eyebrows and everywhere, she was trying to find a silver lining there and was making a joke about it. But just to make the point that body image can be profoundly impacted by a lot of different types of treatments. And for sure, relationship changes can be very difficult for the patient and the partner. It can be very challenging for people that are in long-term existing relationships before a serious illness diagnosis comes around. It can be very difficult for single people starting a new relationship as well and trying to figure out, when do I disclose this history of this serious medical illness? When do I share the different types of treatments I've been through and that I might be expected to continue on to? So I think that, it really depends on the individuals and the relationship. At our cancer center and even in Calgary more broadly, we've got various different psychosocial services. It can be a challenge for people if there isn't coverage for these services, relationship counseling and things like that. There can be some helpful and useful information online, but of course, as we all know, especially in this era of misinformation and disinformation, not all of the information and things that we find online come from reputable sources. So I'd be very, specific in recommending specific areas and resources for these kinds of things. And partners, this is another area that has received relatively little study in the literature, I would say. So partners of any serious illness, not just partners of someone being treated for cancer or a bone marrow failure disorder, partners can sometimes feel worried about causing pain or discomfort during sexual activity, and that might cause them to kind of withdraw or pull away. They also could feel unwanted or unattractive or rejected due to the decreased sexual activity. They might not understand that it's related to the treatment at all. Sometimes the partner has to change from being a partner or a spouse to being a caregiver. And in one study that I did, it was a couple, they were in their mid-20s. They had just been married a year prior to the diagnosis, and it was a major shift. And the female partner said, I had to shift so much from looking at him as being my partner to now suddenly I'm caring for him. And I'm, at times even having to help him go to the bathroom and different things like that. And so it was really hard for people to sometimes shift that mindset from seeing the person as a partner to, seeing them as somebody that was receiving care. So that can be a difficult shift or transition for a lot of people. And we did help people in our clinic with kind of getting back to being the partner and stepping away from being caregiver. And then some partners might withdraw or pull back because they might be worried about the potential loss of their partner if things are looking like the partner might not make it. We also need to keep in mind too that partners also have their own set of health issues and psychosocial issues and concerns and things like that too. So, I've been in the situation too where we fixed the patient's sexual health concerns, but then the partner has sexual health concerns, and all of a sudden there's a mismatch in terms of interest and abilities and function and different things too. So, for patients with partners, we always want to consider both people in that relationship. And, are there other issues that might be impacting the relationship status and satisfaction that way? We know also that there's not enough research and literature about sexual and gender minorities. And so in the US, the estimation is that approximately 12% or so of the US population identifies as LGBTQ. We know this population lacks access to early screening and detection and resources tailored to their needs. And so, some people will say, there's a survey of oncologists talking about how they handle needs for LGBTQ patients. And some of the responses I recall reading said things to the effect of, well, I treat all my patients equally. But that's not what we're striving for in healthcare. We're striving for equity, not equality. And, I thought of, we always hand out handouts to patients all the time about various different things, their medications and things. And it wouldn't be equitable if I said to somebody who is blind, well, here's the handouts we usually give to everyone else. You're getting exactly the same thing, but they wouldn't necessarily be able to read those because they're blind. So we want equity, not equality. We need to find out more about what the needs of this particular population or these populations are, and then tailor the needs accordingly. So that work is being done, but of course it's quite slow. So this is from the cancer care world. I would say that there's probably even less information in the bone marrow failure world about the needs of sexual and gender minorities. And then again, thinking about conditions when someone's not feeling good. So, or considerations. So of course, if there's pain or various different symptoms, nausea, vomiting, diarrhea, dry mouth, all of these different symptoms can make it difficult to want to engage in sexual activity. And so managing these symptoms is really key. Recognizing that sometimes different management options to manage these symptoms, the side effects from these medications we use to manage these symptoms can cause more problems. So, different pain medications and things can impact erectile function and arousal and different things. So we have to sometimes be very mindful about what we're doing. But by and large, if we can manage symptoms and help somebody feel better, that might lead to improved sexual experiences and encounters. And then if you think about it, and again, it reminds me of when I was in the hospice, beds in hospitals are single. And again, it's not about sexual intercourse or sexual activity necessarily, but wouldn't it be great if we had double or queen size beds in hospitals so people could snuggle together and just lay with each other and just be able to have that physical intimacy, even if it isn't sexual intimacy. And you think about also, in the hospital environment, there's lack of privacy. There's all kinds of different equipment that can be in the way of even just simple physical touch and hugging and holding hands and those kinds of things. And certainly we saw this to a huge degree with COVID. The impact of COVID on relationships was very hard. So for single people, dating during COVID was challenging for sure, especially in the early days of COVID. But I always think about patients with bone marrow failure disorders and patients with cancer as being, very vulnerable and high risk in terms of the complications associated with COVID. And again, I did a study, it would have been during 2020 and 2021, interviewing patients and caregivers. It was about palliative care specifically, but a lot of them spoke about the isolation associated with COVID. And they said, but this was something that I've always done because I have, whatever bone marrow failure disorder or post-transplant, and they're very immunocompromised. And so the isolation piece was something that a lot of people with bone marrow failure disorders have contended with for many, many years. And now the rest of the world was contending with this isolation as well. So, and again, we've heard anecdotes and different reports and stories, and there's even research articles that some relationships were made stronger and some relationships it didn't survive the COVID lockdowns. So it definitely added another layer to the complexity of sexual health in the context of serious illness. So now to switch gears and talk a bit about what we do about some of these challenges. And again, as I mentioned, our clinic at the Cancer Center, we lost funding for it, unfortunately, but when we had our clinic for several years, we had, myself, on occasion, we'd have a radiation doctor come in. On occasion, we'd have a oncologist come into the clinic, and we always had a psychologist in the clinic as well. So, this very biopsychosocial approach, because I really feel that all the biopsychosocial components of sexual health are so intertwined. It's very difficult to tease out just the physical or just the relationship or just, one piece or the other. They're all kind of enmeshed in each other. I always feel that there is a role for counseling, couples counseling, individual counseling. Again, we always want to try to really support the partner so they can step aside from being that caregiver all the time and try to go back to being the partner. We've got lots of different options that are non-invasive in terms of helping with sexual function, including things like dilators and vibrators and lubricants and those things. Again, if we can really be careful about managing disease and treatment related symptoms, that can also really help patients with sexual function and sexuality. Pelvic floor physio, I'll get to in a second here. And then referrals. And that was something that our clinic often did, is that we often referred patients to other specialists as needed. Communication is really key. So we found that in our clinic that a lot of couples are not comfortable talking about sexuality or sexual health, even though they've been together maybe for 20, 30, 40 years. If it was not something that they'd been used to talking about early in the relationship, it was not something that they could easily adapt to at this juncture after a serious illness diagnosis. So this was something that our psychologists really worked with patients and their partners to be able to talk to each other about what they need and what feels good and what doesn't. And again, planning sometimes. So unfortunately, the spontaneity piece after a serious illness can be taken away a little bit in terms of if medications are needed to improve symptoms or diminish symptoms. If medications are needed to help with sexual function, there's a little more thoughtfulness that has to go into it. So it's not as easy as being, just good to go anytime and really spontaneous. So there is that shift a little bit as well. One of my colleagues, Dr. Lauren Walker, and Dr. Wassersug, he's from BC, and John Robinson is from Calgary as well. They've got some questions that couples can use to talk about sexual activity and their sexual relationship. And, again, for a lot of patients and partners that we saw, these kinds of questions were quite foreign and quite different and quite scary. And, we were never about trying to impose these kinds of things on people until they were ready. And even when they were ready, we didn't want to impose ourselves or impose these kinds of approaches. We wanted people to, be ready to do this at their own pace. So, these kinds of questions can be very helpful for talking to each other. Things like, what kinds of touching do you most enjoy? Maybe if there's been a surgery or some kind of radiation, it can cause scar tissue to the area, that area might be super sensitive, or it might be completely numb, and the person might not like to be touched there anymore. So it's just a matter of kind of negotiating some of those aspects of, what is good and what isn't. And it's good to have these conversations outside of the bedroom at a time, when people aren't engaged in sexual activity, because then it becomes very, not critical, like I'm thinking in terms of criticism of each other, but it can just be a little bit easier to have this before there's a sexual encounter. Yes, so I'm happy to send these slides as well. I should have mentioned that at the beginning. So so you'll have a copy of these kinds of questions you can use to ask each other. And then improving intimacy. I joke always about this. This top image here is from a Cialis ad. And I always joke, if these two were in the same bathtub, maybe they wouldn't need the Cialis because they would be together with each other. But I mean, we're talking about intimacy. And again, it doesn't have to be sexual intimacy. It can be this emotional, sensual, physical intimacy, but not necessarily sexual intercourse or sexual activity. So it could be dancing. It could be taking a warm bath together, a bubble bath. It could be giving each other massages, different things like that. Again, there's this non-intercourse sexual activities or very erotic, non-insertive sex. So taking intercourse right off the table, especially if there are challenges with erectile difficulties or really painful vaginal tissues. It might take us time to get things improved to the point where it's comfortable for one or both partners. And so in those circumstances, we say, don't put too much pressure on yourself or your partner. Let's just take sexual intercourse right off the table and let's do other things, because those other things can be very pleasurable and satisfying as well. But sometimes it just takes a bit of a mindset change. And then there are special exercises, and these are done usually with a trained counselor with the couple individually or a patient individually. And one particular exercise is called Sensate Focus, and this usually occurs over a period of several weeks. And that can, the goal again is there's no even genital or breast touching or anything like that at the beginning. But over time, the patient and partner talk to each other, or the couple overall. Again, it doesn't have to be a patient, it could be just a couple in the absence of a diagnosis. Talk to each other, touch a bit, figure out what feels good, what doesn't, what they like, what they don't. And by the end of the 5 to 6 week period, if intercourse is desired, it may be tried at that point, but there's no pressure. And early on, it's just about communicating with each other about what feels good and what doesn't. So again, a lot of counselors have training in this area, this sensate focus. And improving desire, again, I think we found in our clinic that if we could address some of the other challenges, so especially if there was painful intercourse, dealing with that first could then lead to better desire, but also this awareness that even if desire isn't there at the beginning, there can still be a very satisfying sexual encounter. So it's kind of, think about it at the beginning where we always used to think you have to have that desire first before any of the other stuff will happen. And then, the orgasm is the be all end all. Well, no, we know now that there can be a very satisfying, enjoyable, pleasurable encounter in the absence of desire at the beginning and even at the absence of orgasm at the end. So it's all about, again, communication. Sometimes counseling can be helpful here. Mindfulness-based meditation. So a lot of people, even during an intimate encounter, are making lists in their minds of things they have to do later in the day. They're thinking about, the groceries or picking up the kids from school and, I need to do all these other things. But being right in that moment and feeling all the sensations in the body, the awareness of a partner's breath, the awareness of a partner's skin and how that feels. And all these things are just really being in the moment can really help with that satisfying sexual encounter. And erectile function, we know this from all the different TV ads and things like that. There's lots of different things that we can do to improve erectile function. We always in our clinic would start with figuring out what were the reasons, and usually it was reasons plural for difficulties with erectile function. So it could be medications, it could be pain, it could be blood flow issues, all kinds of different things. And that kind of helps direct how we would then intervene with different strategies. But there's lots of different things on the market. So of course, the most common or popular that we hear of all the time are the PDE5 inhibitors. There are penile prostheses or strap-ons, dildos that can be used. The Elator is a device, I believe it's created in the States. It's custom made to the length and the girth of the man. It's about $350 US. And so you can see it's just a device that helps to position the penis in an upwards position to help aid with penetrative intercourse. Constriction rings, so that can help to keep the blood in the penis to help. So if there's an issue with this is just one type, there's lots of different types. And that can help to trap the blood in the penis to help with sustaining an erection. And constriction rings are often used with vacuum erection devices, and I'll show you a picture of that in a minute. And the injections and the implants I'll talk about as well. So the phosphodiesterase type 5 inhibitors or PDE5 inhibitors. So there's sildenafil, Viagra, vardenafil is Levitra, and tadalafil, Cialis. In the States, they've got Avanafil. We don't have that here yet. They all work much in the same way. So ultimately what they do is they improve blood flow to the penis. And that leads to an erection. So if there's a really bad nerve function that's been impaired, really bad nerve damage, these medications won't always work because we still need the nerve function to work. So this is helping with the blood flow problem, but it doesn't always help people who have really bad nerve dysfunction. And that can be neuropathy, it can be from surgery, it can be from a variety of different reasons. These medications are typically taken as needed. And again, this is where the planning comes in, is you have to take these about 30 to 60 minutes before sexual activity. There is now the option of the daily dosing for tadalafil. So standard dose of tadalafil would be, 10 to 30 milligrams. But you could take 5 milligrams every single day, and that allows for more of a steady amount of that drug to be in somebody's system the whole time. So they'd be more good to go, so to speak, so they wouldn't have to think about taking the pill before sexual activity. The difference between these medications, they all work the same. As I mentioned, tadalafil's got the longest half-life. And I think about this because the very first prescription I wrote for Cialis, or for Viagra, sildenafil, the patient and his partner had a lovely romantic dinner, they danced, and then they both fell asleep. And they woke up in the morning and the Viagra was out of the system. So had it been tadalafil or Cialis, it's also called the weekender, there would have still been enough of that medication in the system that there could have been a possibility of erection even a day after the patient had taken it. That doesn't mean that somebody will be walking around in the upright position the whole weekend. It just means that there is that opportunity because that medication lingers around the body longer than Viagra or Levitra would. The only big concern with these medications is that if somebody is taking nitroglycerin, which we sometimes give to people for chest pain, taking one of these drugs can also cause, at the same time, can cause really, really low blood pressure. So we don't like people to take these, obviously, if they're taking nitroglycerin. Regular blood pressure medications are not a problem, but nitroglycerin with these medications is a problem. This is why Avanafil has got a very, very short half-life. And so if somebody had chest pain the next morning, theoretically, they could potentially have nitroglycerin as well. But as right now, that's the major contraindication is giving nitroglycerin or taking one of these when somebody's had nitroglycerin. The other options, so intracavernosal injection therapy. So as you can imagine, not everyone is keen on injecting medication into the penis. It is a very, very tiny needle. It's a diabetic needle. I thought I had one here somewhere to show you. I might not. It's a teeny tiny needle. It's injected into the side of the penis. I did teach men in our clinic how to do this. This option works very well if it's a neurogenic or if there's a really bad nerve dysfunction or reason for a really bad problem with the nerves. So even when people had nerve damage from prostate cancer treatment, this option could still bypass that need for that neural input, and they could still achieve good quality and firm erections. And so typically we would teach the man or his partner to do the injection right in the clinic. We would do it, and then they would go home and they would self-inject or have the partner do the injection at home. Transurethral therapy or medicated urethral system for erection muse involves putting a little pellet in the urethra, and we don't use that as often. There's a cream that I don't know if it's on the market yet in Canada, but in the States they've got it, alprostadil cream, and I believe in Europe they have it as well. And it would be a cream that would just kind of be placed here and would seep into the urethra and then get absorbed into the corpus cavernosum and lead to vasodilation or blood flow in. It works about, the Muse system works about 20 to 40% of the time. The injections work about 85 to 90% of the time, so quite effective. And again, even when there's nerve problems. The vacuum erection devices, and they work by pumping blood into the penis. And then again, as I mentioned, you place the constriction ring at the base of the penis, and that traps the blood in the penis so that there can be sexual activity. You need a really good quality device to get a good seal, and a good quality device costs in the neighborhood of $300 to $400. Well, a couple $100 plus anyway. But if you get a good quality vacuum erection device, it's effective. It can be 90% plus effective. And then the penile implants would be probably a very last resort, because these are placed surgically, and that you can have a 2 or 3 piece design. So there may be a reservoir in the scrotum, and that can be squeezed, and a fluid will then go into the cylinder in the penis. And then, there could be a reservoir either in the scrotum or in the abdomen, and that would be pumped up, and that would inflate the cylinder. And then after sexual activity, it can be released and the fluid drains out. Or the other type is the semi-rigid or semi-malleable rod can be placed, and then you can just adjust the penis to the desired angle, and then the sexual activity can occur that way as well. So those are surgically implanted, so not first line, obviously, but can be very effective, 95 to 100% effective. And then for vulvovaginal symptoms, we really want to help manage the dryness and irritation that can happen. This can happen again, of course, from natural menopause. And so I think this content is relevant for anybody with a vagina. So just like the skin on the face, we recommend women moisturize the skin of the vagina after menopause, because the loss of estrogen can cause those tissues to be very friable and very dry. And so using a good quality moisturizer at least 2 to 3 times a week in the vagina. So again, the vulvar tissues on the outside, the opening to the vagina, and then the inside of the vagina, all those areas need to be treated. And there's all kinds of different products, and I'll get to those in a second. And dilators and vibrators can be helpful, especially in the context of graft versus host disease, or if there is shortening because of hysterectomy, or even if there's significant loss of estrogen that can cause the vagina to be very tight and it can get even a bit shorter. And then, yes, if there's no contraindications, sometimes we'll use a tiny bit of local estrogen, so vaginal estrogen and vulvar estrogen. Again, I mentioned counseling and psychotherapy, I think, is very helpful. Things like the Mona Lisa therapy, laser therapy, as of right now, the data is equivocal. So it's not showing significant positive results in terms of improving vulvovaginal health. So it's almost like burning off the upper or the outer layer of cells with the thought that those cells will regenerate, regrow, and they'll be healthier. But for someone that causes more scarring and pain, and at this point, we're not recommending this as a standard therapy. So again, the differences between moisturizers and lubricants. Moisturizers are intended to help keep those vulvovaginal tissues healthy. Lubricants are intended to be used to make the surface more slippery. So that would be for sexual activity or for pelvic exams, or some women have very dry vulvar tissues and vaginal tissues that even riding a bike can be uncomfortable. So using a lubricant can help with those symptoms, but the lubricants are not going to improve the health of the vaginal tissues. Whereas there have been studies that have shown that if you use a vaginal moisturizer diligently, you can improve the vaginal pH, you can improve the health of the vaginal tissues, improve the elasticity, and that can make sexual activity more comfortable. But you definitely need to be diligent using these a few times a week, and then maintain for at least 3 months before you see optimal benefit. There's all kinds of different examples. Some people are sensitive to the preservatives. So Replens has a preservative called propylene glycol, and that can be irritating to the vaginal tissues. And others, if they have sugars in them, if someone's prone to yeast infections, we want to be careful about that. So always check the ingredients. You can use vitamin E capsules, where you can just puncture a little hole in one of these and squirt that and rub it over the vulvar tissues and the vaginal tissues, and that can be very helpful. Lubricants, similarly, lots of different lubricants on the market. We recommend usually water-based or silicone-based. Oil-based can erode condoms, and some people have reported infections and things with oil-based, but water-based or silicone-based can be very helpful. And dilation, again, too, if there's been a period of prolonged abstinence or time where there hasn't been much in the way of sexual activity, dilators can help a woman regain confidence, and they come in different sizes and shapes, and the silicone ones are quite pliable and flexible, and you can order them in a set or individually. And again, so this wouldn't be in the context only of cancer, but in the context of if there's been a prolonged period of time where someone has not had sexual activity, if there's been profound loss of estrogen, even postmenopausally, some people will find dilation very helpful. There's instructions that are really helpful. I find this is Memorial Sloan Kettering Cancer Center in New York. They have a great handout on vaginal dilation. And graft versus host disease, for sure. We want to see women dilating just so that they're not, vaginal graft versus host disease can cause almost it's a circumferential buildup of tissue almost, and it can slowly cause the vagina to close in a bit. So that can become an issue for sure. And vibrators can be used by both males and females. There was a study a number of years ago that was looking at vaginal dilation in women who went through gynecological radiation for pelvic cancers. And the thought was that the vibration might lead to improved blood flow, and that might lead to improved healing. But they can be used by men and women alike. And sometimes in our clinic, we would have women and men try them to see if that helped with sensation and different things like that. There's different types. This one's called the Guyberator. It's one that can be used with a flaccid or semi-flaccid penis even. So it can be helpful for some men with erectile challenges. And again, you don't need an erection to have orgasms. So that's something that in the prostate cancer world, we do a lot of teaching about. So an erection is not needed for orgasm. You can still have an orgasm even in the absence of an erection. We referred a lot of our patients to pelvic floor physio because, again, that hormone environment change could be really significant in terms of what it did to the pelvic floor. And again, this can be profoundly important after menopause or for other medical conditions as well. And even our male patients, we often sent to pelvic floor physiotherapists. You need somebody who's trained specifically as a pelvic floor physiotherapist, and they can be very helpful. I won't get into hormone use after cancer specifically, but just to say that sometimes we have recommended a very low dose, short duration, local estrogen therapy. So that would be to the vulvar tissues, the vaginal opening, and inside the vagina. And that could really help to restore the vulvovaginal health. Again, if there's history of hormone receptor positive breast cancer, this would be very cautiously used, if at all. And it's the same with testosterone as well. So if there's a cancer that could grow in the presence of testosterone, such as prostate cancer, we'd be very cautious about using testosterone replacement therapy, although that would be a discussion with the individual patient, their oncologist, or their doctor about the risks and benefits in both those cases. And herbal or natural products, just be very cautious. This is Memorial Sloan Kettering Cancer Center. They have a great website. You can punch in pretty much any herbal product and it will tell you what it's used for, what the warnings are, what it could interact with, and things like that. So just because it's an herb or something like that, it might seem natural, it can still significantly interact with other medications and things like that. So we want people just to be cautious about that. That's not to say that we would say it's not safe or whatever. We just want to be cautious. And then safer sex, of course, is something that we talk about with a lot of our patients always is, we know that there can be exposure to medications through vaginal secretions, semen, and things like that. We don't know for sure how long after chemo this could happen because there have not really been any good quality studies done looking at this. Most centers recommend that after chemotherapy, that you use condoms or dental dams for at least 2 to 3 days. And then the most of the chemo would be out of someone's system. That becomes a little more difficult when it's a daily chemo. And so, we talk about strategies and ways to get around that. And then when platelets are low, there can be potential for increased bleeding and bruising. So very rough sexual activity can be difficult and can be damaging. So again, we have conversations about what is safer sex. And similarly, when the white count and neutrophils are low, there can be potential for increased infection. So things like, rough anal intercourse and things like that could introduce infection and could be a bit of a worry. But for the most part, sexual activity is okay during treatment, provided that the patient is feeling okay and that some precautions are taken. And so it depends on the medications that are being taken. It depends on the age of both partners, because of course, if someone's of childbearing age, taking medication like lenalidomide or Revlimid, it's teratogenic. So we'd want to protect the patient and the partner from being pregnant or impregnating someone and things like that. So those are cautions I'm sure that each patient's doctor would go over, but by and large, these are just some broad considerations. And so just to close, just to say that, it's not all about sexual intercourse or sexual activity. There's a lot of different types of intimacy, relational intimacy, and then even physical intimacy, but not intercourse based. And then there's erection dependent sexual activity where there's some different strategies and things we can do to help with that. But there's a lot of different things we can do that don't involve penetrative intercourse and actual sexual activity specifically. So it's all about the bigger picture about preserving intimacy, what's important to the couple and the patient specifically, and going from there. This is a tear out tool. This is in the context of multiple myeloma, but a lot of these same questions would be relevant for really any diagnosis. There is a question on here that I don't love. So it says lack of orgasm, lack of complete satisfaction. I don't think that those two need to be tied together. So you can still have lack of orgasm and you could still have satisfying sexual encounters. So again, it's sometimes just about altering our expectations a bit, or not altering them, but maybe rethinking them. We know it's very common for changes in sexuality and sexual function to happen after a serious illness diagnosis and treatment. There's lots of different strategies we can look to use to help improve function and sexuality. There's all kinds of assumptions we all have, I think, when it comes to sexual function, but really there's no right amount of desire, no perfect relationship, and no such thing as a normal sex life. Really talk to your healthcare provider to find out what options might be available. Keep an open mind, try something else if the first option doesn't work, and just keep talking to each other, to your healthcare provider, and don't give up. And I will stop there. And I can take questions, or again, as I mentioned, I'm happy for people to email questions in as well. I think when this gets posted, it will have my email address as well. So there we go.
Thank you so much, Reanne. I don't know whether anybody has any questions. I've opened up the ability for our participants to speak. Douglas, I see your hand is up. I don't know whether that's from previously when we didn't see that you were on the call, or whether you do have a question now. No, okay.
One thing I was going to show real quick, Cindy, if it's okay. There's a product called the O-Nut, and I want to bring it up because a lot of women that we saw in our clinic would talk about, again, if there was hormone changes, the vagina can get drier, shorter, tighter, and a lot of women would say that it would feel like their partner was poking up against something and that would hurt, and it could be the cervix. So depth of penetration could be quite painful. So the O-Nut, it's this series of stackable rings and they're soft, they're silicone, they can be placed on the penis, and that can control depth of penetration. So a lot of women would say that it would just feel like it's too deep, it's hurting too much. So a lot of women would try this. You can use your hand to stop depth of penetration. You can use a folded towel. But a lot of men have reported that it feels like kind of like a tight hug around the base of the penis, and it can help prevent that really deep, painful penetration. So that was something I meant to mention earlier and forgot.
Okay, well, I don't think we have any questions. So thank you again, Reanne, and thank you to our participants. And we will be putting the recording up on the website.
Great, thanks very much. And yeah, happy to have emailed questions if that's easier too. Thanks very much.
Okay, good night.
Good night.